So femur defects in complex primary and revision scenarios. How do you understand them and how do you deal with them? First message is, very often they will not be standalone. You will have something happening on the acetabular side as well. So you have to manage both. Very often, to manage one, you have to take care of the other as well. So if a hip is gone, inside or intrapelvic, very often you will need to do an ETO to get the hip out and then deal with the hip deformity as well as treat the femur deformity. Very often, the hip biomechanics that you want to restore and you have a femoral remodeling defect, you will have to understand, recognize and deal and choose an appropriate stem which will give you the perfect balance on the femur side to be able to have a stable, well-balanced hip. So essentially, deformity can be classified into various situations. So the defects can be because of a revision situation, and deformation can be in a complex primary and a revision situation. And invariably, that is, we will be faced with people, young adults or slightly older adults who will need total hip arthroplasty or revision hip arthroplasty, which is secondary to the developmental process, which is secondary to trauma complications, which we see a lot of, and which will be secondary to childhood osteotomies or adult osteotomies done for various indications in various situations. All of this will cause a malalignment of the mechanical axis and thereby a distortion of the hip biomechanics, and that is what we want to put back. So you're not only looking at what is visible from the front, a coronal plane deformity, but it is extremely important to know what is visible from the side. So the sagittal plane conformation is as important as a coronal plane deformation. So when you're seeing something from the front, what you want to see is what is happening to the neck, what is happening to the GT and the LT, what is happening at the level of the metaphysis, and is something happening at the level of diaphysis. When you see the same thing, pathology from the side, you want to see whether it is angular, whether it is rotational, whether it is translational, or invariably it is a combination of all these. And those subtle changes, if we do not recognize preoperatively and plan for it, we will run into intraoperative problems and complications. So the next most important message is, the more time you spend on the drawing board, the more time you spend thinking about your plan A and having a plan B and a plan C, the better and easier your execution will be. And the single most important take home is, if you can spend optimum amount of time on the drawing board, you will spend less time on the table and you will have lesser complications, and that is to be done on every single case that you treat. So that is a classification of how the femur defect can evolve and how the deformation of the proximal femur anatomy can happen. It can happen basically on different levels and because of different etiologies like we just discussed. A very straightforward example which we see on a daily basis. A DHS done, this is a coronal plane deformity. Site of deformation is metaphyseal. The geometry of the deformation is that there is a translational anomaly, and the etiology is that it is a malunited proximal femur fracture. But the day this hip wears out as it is starting to wear out, you can't use a primary stem. You have to think differently and you have to look at modular options in like an SROM stem. Another situation, femur neck deformities, right? Coxa vara and coxa breva. The neck is shortened, the neck has gone into varus, the neck shaft angle has gone bad. So another important message is, however simple your hip may look, always look at the neck shaft angle also. Because very often we walk out very happy with beautifully done total hip arthroplasty or revision arthroplasty, but you will find your patient complaining, having a limp, complaining of some nagging pain, something, complaining of some abductor weakness, complaining of some altered limp. And these are patients where we have not restored the neck shaft angle. And that is something we don't see very often, but that essentially says you have a higher offset stem available on the table. And you plan to restore the offset both on the vertical offset as well as the horizontal offset. So that balance is very, very important. So septics equally, the hip gone bad, obviously the focus is on the hip side, but also consider the soft tissue tension which has gone wrong, also consider that there is a varus remodeling, also consider that the proximal metaphysis can be a little wider than the shaft. So it's like a deformity happening on the proximal femur also. Most of the times we are looking at the spinopelvic balance here. Most of the times we are looking at the hip acetabular deformity, and we forget to do enough for the femur side, and this is what we run into the problem we run into on the table. So that's a very important thing we need to understand, factor and template, because the hip has to belong to where it is supposed to be, and you do the Ranawat's triangle to plan where your cup needs to rest, but you also need to understand where your acetabulofemur balance has to rest, and a lot of times these hips will need a proximal femur osteotomy, which means automatically you have to go into a modular solution or an S-ROM stem. Coxa varas, again a neck proximal femur problem, and this is something we will run into almost on a daily basis. The more hips and knees we do, the more we will run into trauma complications presenting for arthroplasty solutions, and this is something that we see almost every day. Beautifully done hips or not so greatly done trauma fixations, the implant wearing out, the implant cutting out, and walking into the acetabulum, presenting with defects and presenting with proximal femur problems also. So again here the focus very often is on the acetabular defect, but if you look at the femur, you've got an abductor which is bad, you've got a distal femur which has translated, and you've got a proximal femur which is wider than the diaphysis. So you've got a whole lot of problems on the femur side. The acetabular defect will just take a graft or will just take an augment, and you can get in an anatomical center of rotation with a standard cup as you have templated on the contralateral side. Again, solutions need to be tailored to the problem at hand. The acetabular solutions are very simple, but you need to factor in what you will do. So always have optimum femur stem which will do all the jobs for you. So these are not situations where your metaphyseal fixing stems will do the job. You need to have a diphyseal fixing stem because the abductor is not so great, because the proximal femur is ectatic, and that is where your proximal femur fixation will not hold, and you need something on the distal diaphysis or the isthmus which will give you a perfectly balanced stem. In addition, if you've got abductor insufficiency, go in for a dual mobility. Coxa valgus, and these are patients who will present in late adulthood with deformations. So bilateral DDH, they do well till 30, 35, and they start presenting at 35, 40, 45 with severe pain in the hip. So you have to classify whether you are dealing with something which has a formed acetabulum, which is a C2, or a not formed acetabulum, pseudoacetabulum, which is a C1. And there are a host of problems with these patients. So there is no acetabulum, true acetabulum, they have an altered neck shaft angle, they have a short femur neck with excessive anteversion, they have large medial cortical inclination, they have a high GT position. So host of problems which need to be addressed, and these require modular femoral solutions. So that is a case where you need an S-ROM stem, right, or a conic or a titanium cone tapered Wagner stem. So you need to factor in where your mechanical axis is. You need to factor in how you will reconstruct and put the hip back to where it belongs. So very, very important to identify the problems and then choose your plan A and also your plan B for the table. And this patient underwent a reconstruction of both the sides, staged reconstruction with proximal femur shortening osteotomies, subtrochanteric shortening osteotomies with autografts, and with a very decent reconstruction of the hip. But despite these reconstructions and despite alignment of the mechanical axis. These are patients who have not walked for 35 years of their life with their normal abductor mechanisms. So they will take a lot of time for their abductors to heal, and this lady still walks with a limp. I'm sorry this video is not playing, but this lady, even though she's got a very stable, painless range of motion, she still walks with a little bit of a waddle. And you have to explain to these patients that these hips will take time and these abductor mechanisms will take time to recover. Greater trochanteric deformities, again similar issues. You have high riding trochanters because of either deformities or defects. Solutions have to be tailored to individual problems. Again, the most important thing is to put the hip back. Very often you will be able to get out with a metaphyseal fixing stem. Sometimes you will have to give certain specific solutions to these proximal femurs. Trochanteric malunions, again, what we see here is the acetabular defect. What we see here is the acetabulum which has gone wrong, the neck which has gone avascular. But what we don't see here is the GT which is not united, which will cause an abductor dysfunction, which has caused a proximal femur problem. Again, if you use a metaphyseal fixing stem with a standard cup, you might land up into not restoring your biomechanics, your horizontal and vertical offset correctly, and thereby getting a hip or a hip instability which you don't want. So that is very important to factor in what you will do, the defect understanding, the defect reconstruction. And this is one patient where we had a fracture on the table. So we had to do a stabilization of the fracture with a plate, so that this patient ultimately went to healing and walked very well. Again, bilateral dysplastic hips. This was a gentleman who had not walked for 25 years. He came into the OPD with this. And if you see the proximal femurs, the problem is not only with the hip, the problem is with the proximal femur also. So there is a varus remodeling on both the sides, and it is very important to understand varus remodeling. So if you see the proximal femur and if you see the distal femur, they don't belong to the same plane. So there is a medialization, there is a torsional element, and if you start at the correct entry at the GT where you start your normal stem, I will walk out of this femur. So that is something that needs to be factored into your pre-op planning, and you need to change your entry so that you enter in the correct place. So we did a staged bilateral total hip for this gentleman, and this patient also needed a bilateral total knee. He had a severe flexion valgus. On the right side, we stemmed using this varus valgus constraint. But because both the stems were so close by, we had to put in a plate so that we do not walk into an intercondylar failure and an interprosthetic fracture. On the opposite side, we realized the deformation and the correction required was lesser, so we were able to get out with just this, and this patient is now 1.5 years post-op and walking comfortably. Though he's formed heterotopic ossification on both the hips and his range of motion at the hip is less, but he's still walking pain-free after not having walked for 25 years. Metaphyseal deformation, we will see a lot of these. So the first message is choose your stems wisely. Don't just put in something because the patient cannot afford it. You try and justify the cost of a decent implant for your patient. And the most important thing to identify here is the concept of the femur deformity, which is proximally there is a straight cone, distally at the level of isthmus there is a cylinder, and as you go down there is a reverse cone. So essentially you have to see which part of your femur is actually having a deformity, whether it is the proximal femur or the isthmic region or the diaphyseal region, and that is the Paprosky classification for you. So you have to know what are the modes of failure, where your defect is, what is the kind of forces that your hip is being subjected to, and then you choose how do you take out this stem, how do you bypass this deformity. So there are lots of solutions. You can create a cortical window, you can make a long sleeve, or if nothing else is going to work, you have to do an extended trochanteric osteotomy. You have to be on the drawing board, plan your hip well, choose your steps, write them down, think them over before you do procedures, which will take a little more time than what your normal hip and knee will. So this is the patient, did well, had an acetabular reconstruction and got a distal fixing stem. Another patient, similar situation, similar result. We had a perforation while introducing the stem, but which we could manage with just wire fixations, and this patient had a delayed weight bearing, but eventually did very well. So the take home is that you have to understand, if you've got cortical perforations, varus remodelings, what is the mechanism of the failure, what is happening to those stems, certain other comorbid factors like BMIs, high functional demands, quality of bone stock, and the kinds of stems that you are working with in these revision situations. Last is diaphyseal deformities and metaphyseal deformities in combination. So this is a gentleman which presented with something like this. This is not an uncommon situation, multiply operated, multiply scarred, fixations removed, and this is what he presented to us with. So he needs not only an acetabular reconstruction, but he needs that segment of the diaphysis whose vascularity has to be restored, it has to be put back into alignment, and a titanium fluted tapered stem is a very good solution for these implants. You could use a modular or a non-modular variety depending upon what your practice is and what your patient is going to afford, but these patients did very well. And this is a case from Professor Malhotra sir, where he's dealt with a proximal femur deformity, where we've just bypassed the deformity and done a proximal reconstruction. So this was a gentleman presented with this kind of a deformity, multiply operated, proximal femur and a distal femur deformity. What do? You don't need to take the metallosis off the proximal and distal femur all the time. So simpler solutions, lesser pollutions, less is more, and very, very simple solution to a very complex problem. A dual mobility articulation and a short metaphyseal fixing stem. And this patient walks very, very well. So tailor your solutions to individual problems. That is very important. More importantly, you have to know what is the etiology of the problem, what is the anatomical source of the complexity of the problem that is presenting to you with. You have to choose the right approach for your different situations. You have to factor in what is your plan A, whether you're going to use modular stems or non-modular stems, or what kind of versional issues you need to address with on a coronal and sagittal planes. Post-op pre-op evaluation is very, very important. The more time you spend on the drawing board, the better reconstruction you will be able to give your patient. And modular and non-modular stems both have excellent survivorship, and they are wonderful reconstruction options in difficult situations. Thank you.